Okay, so next up is Matthew McDaniel, our lead physiology modeler on the project. Great guy. He's stationed out in Denver, and he's done a lot of work on BioGears in the past couple years. So he's going to speak to a little bit about new models and capabilities. He has extensive mathematical biological experience. He has his master's from NC State in mathematical biology. He's been on the BioGears team since 2017, so almost 3 years now, I think, Matt. And so we'll unmute you, and you can go ahead and present.
All right, thanks, Austin. So I'm going to go into this next talk just in some more detail about some of the new models and capabilities that BioGears has now that we've gotten a lot of these new contracts, opportunities to pursue some new work. So just a brief outline, just give some of the motivation for these new models. There's three main ones that I want to highlight. The big ones are Inflamation Model, which we've applied to infections, sepsis, burn wounds, and it also caused us to do some work to help with antibiotic pharmacodynamics. We've done some expansion of our Cerebral circuit model, and I'll briefly mention our whole blood model we're working on. One of our other developers, Nathan, is going to give some more detail on that later in the conference, so I won't spend too much time there. So our motivation, as Austin mentioned earlier, the start of BioGears, our motivation came from our early contract, and we awarded a follow-on contract that is helping to drive some of this model development. And now we're starting to collaborate a lot more with other divisions at ARA, like Virtual Heroes, or just the medical simulation community in general, United States Army Surgical Research, University of Washington, specifically there, the Advanced Modular Mannequin team. These are all groups that we've gotten a chance to work with, and they've given us some great feedback, and we've gotten to interact a lot and do a lot of model iteration with them, and it's been extremely helpful. And then community outreach also on GitHub, we're hoping that that becomes a driving force in the future for some of our model development. I want to jump right in by talking about our inflammation model. This is a pretty substantial model that we added to BioGears, and it's so extensive because it mediates both thermal trauma, so burn wounds, and infections. So we had a contract, Austin mentioned, called Burn Care with USISR. We're looking at physiological modeling of burn wounds. We're also working with Advanced Modular Mannequin to do a model of sepsis, and then our prolonged field care contract has interest in infection and sepsis also. And so our goal was, instead of making different models for every single situation, let's try and make a general model of inflammation that is the driving force for the physiological response to any type of inflammation source. So for burns, infections, and not active yet, but hopefully in the future, hemorrhage wounds also. What I want to mention specifically is really what we added to this model that's new is the part that's in orange, the actual inflammation model, and how that affects certain outputs, this tissue damage parameter if you're accruing excessive inflammation. Nitric oxide is a substance that causes blood pressure decreases. But most of this image here is already existing BioGears functionality. So we have this representation down here of our fluid circuit. Austin mentioned that's how we drive blood flow through the vascular space in BioGears, and also how we exchange fluid with the tissue. We have our cardiovascular model with feedback that gives heart rates, systemic resistance based off baroreceptor inputs, renal feedback that adjusts glomerular filtration rate. Those were all existing models in BioGears, and then we got to plug in this inflammation model and just kind of tune the response to get satisfactory output. So all the work we put in earlier to these models really made a difference in getting this new model implemented. So just mentioned that both burns and infection kick off this inflammation model, causing this cascade of events. And then we have treatment models as well. So we have, you can give fluids to the patient, you can give antibiotics to combat the infection, pain medication, and also blood pressure support drugs like norepinephrine. So a little more detail just on the actual inflammation submodel of this system. So again, this can be initiated by both a pathogen or a burn wound. So the pathogen, we assume that it originates in some local tissue area where local macrophages and neutrophils try to eliminate it. Some of that pathogen can cross the tissue barrier and enter the systemic circulation, and that causes this system-wide response that either is enough to suppress the pathogen, or if it kind of leads to runaway inflammation, you can start seeing systemic inflammatory response syndrome, potentially leading to sepsis. Thermal trauma, we assume, again, this activates the systemic inflammatory response, and it inflicts kind of an initial hit on the global tissue health. But what you can see here is that there's a lot of interaction between these, between all these inflammatory mediators. We got a lot of information from some great work that other groups have already done with this modeling. So it's a pretty large system of differential equations. And so a lot of the parameters, again, taken from great work by other researchers in the literature and then just kind of tuned to fit some of the BioGears response. So I mentioned that covers this orange part here, this inflammation model. I do want to mention some of the fluid circuit adjustments we make. One of the primary outputs of the inflammation model is this tissue damage parameter, and we use that parameter to adjust our fluid circuit resistance. So every single BioGears vascular compartment, so we have, for example, the muscle, the skin, the liver, every single one of those compartments has a corresponding interstitial compartment, a tissue space that it communicates with. And so normally fluid flow across this pathway, this resistor, which represents the endothelial barrier essentially, normally filtration across there is very minimal, and whatever does filter across that barrier is returned by the lymph system to the general circulation. But what we do in the case of excessive inflammation with this burn model, and also with the sepsis model, is as damage accumulates, we decrease the hydraulic resistance on this endothelial barrier, this resistor right here. And what that does is it allows more fluid to travel across that resistor, and it brings with it albumin. And so albumin is one of the primary colloids in the body that contributes to osmotic pressure. And so albumin is a substance that we track in BioGears. And so what you see is that we have some fluid filter across this resistor, albumin travels with it. As we get more albumin traveling, we use the relative concentration of colloid on each side of this membrane to calculate a osmotic pressure. So the more albumin on the vascular side, you have a larger pressure gradient favoring fluid retention inside the vasculature. As you lose that pressure gradient, you see more and more fluid leaking into the interstitium. And so this is how we actually capture, both in sepsis and in burns, you see a pretty large fluid shift, relative hypovolemia, essentially, from the vasculature to the tissue spaces. And so as part of our treatment model, we want to be able to not just cause inflammation, but also be able to treat it. And specifically with attention to the infection model, we wanted to add a antibiotic pharmacodynamics model to BioGears. And so this is a relationship that's been used, again, in various other studies. But essentially, we assume that the antibiotic in question is affecting the net bacteria growth rate. And so the bacteria has some maximum growth rate in the absence of antibiotic, and this is just a parameter that we set in our model. There's a minimum growth rate imposed by the antibiotic. This is a parameter that we tune for a given antibiotic. Of course, less than 0 would imply that you're actively killing bacteria. And then we track the antibiotic concentration in BioGears. This is controlled by our pharmacokinetics model that Austin's going to talk about a little bit later today. And then we look at the MIC, the minimum inhibitory concentration of the bacteria. This is something that users can set when they define an infection. So when you make an infection action, you can control basically how resistant is this bacteria to antibiotics. And so this is a useful equation because when the antibiotic concentration is less than the minimum inhibitory concentration, you see a slowed growth rate of the bacteria, but you don't see active death. And then once the concentration of antibiotic exceeds that MIC, you get bacteria death. And it's a nice model as well because what users have to set is a minimum growth rate, essentially, rather than using a more generic EC50 type of pharmacodynamic equation. It's a little more intuitive, in my opinion at least, to set a minimum growth rate for a bacteria than to try and figure out, what's a reasonable EC50 value for a bacteria antibiotic pairing. And so what I want to do is demonstrate just some results of these models. So with infection, I just want to show comparing 3 different infection levels. So right now we have what we call mild, moderate, and severe infection simulations. I'll show what it looks like when we administer antibiotics, and I'll also show how the model responds when you treat a patient who is septic, so giving them fluids, giving them pressors, norepinephrine, and just show how our model actually has different outcomes depending on the type of treatment chosen. So I wanted to mention, this is kind of what infection action looks like in BioGears. We have this infection data type and a severity, and again, this is where the user can set the minimum inhibitory concentration. So a higher value is going to mean that it's going to be more difficult to eliminate using antibiotics. You can set a location right now. Currently, our model is mostly looking at kind of the global bacteria population. In future implementations, we want to try and model localized interactions better, get a little higher ratio, essentially, of or a resolution, I should say. That's kind of future work. I will note that infection scenarios are very long. These are 48-hour scenarios we ran, which takes about anywhere from 6 to 8 hours in BioGears. So this is where it's very useful that in BioGears you can load previously saved states. So we simulated out several infections and we kept saving them every so often. That way you can load them back in and do treatment simulations without having to rerun these very long scenarios. A quick burn wound demo as well. I'll compare what happens with 3 different burn wound sizes, 10%, 25%, and 40% total body surface area. So this is the output of our inflammation model with 3 different cases, again, mild, moderate, and severe. You can see that in the severe case, the green line, you see kind of a explosion of bacteria in the bloodstream. So it's not eliminated. So that would be what we consider a septic case in our model. In the other 2 cases, the bacteria is gradually eliminated over the course of a day or 2. You can see, again, this important output, this tissue integrity and this damage parameter, again, it recovers in the mild and moderate cases, but in the septic case, you see that global tissue health is deteriorating across the model. And what that translates into in BioGears, elevated heart rate, elevated respiration rate, you do see fever, and then an elevated white blood cell count as the model progresses. right here is just a closer look at the severe case, so leading to sepsis. And so our model does show outputs consistent with the sepsis 3 definition for sepsis. So a systolic blood pressure less than 100, tachypnea and respiration rate. And then we do show some signs of renal organ failure because of a lower urine output. You can see in this figure in the upper right corner, urine output is dropping, so indicating a very poor state of fluid health. And then septic shock, we define that as a mean pressure less than 65 and high serum lactate levels. You can see mean pressure is dropping below 65, and our serum lactate levels are increasing above that kind of critical level. And running through these pretty fast, but I will say that we do have a couple of publications about this model. So we've got an open source publication that goes into a lot more detail about how these scenarios were constructed, and a lot more detail about the model for more information on those. And again, treatment. So on the left side here, this is the antibiotic model at work. So our model substance was a combination of piperacillin and tazobactam. You can see that our model, our PK model, tracks piperacillin concentration in the plasma quite well. We approach the area under the curve reported in the literature, again, very well over the course of the infusion. This parameter, how active is the antibiotic? You'll notice the blood bacteria is decreasing in population, and that's leading to a recovery in the tissue integrity. So you're seeing some improvements as the bacteria is eliminated. Again, more detail, this figure on the right, more detail in our publication, but we looked at 2 different treatment strategies. The strategy on the left was early goal-directed therapy, so early fluids with kind of large fluid boluses. The right-hand side in the orange, that was early pressor therapy, so norepinephrine and reduced amounts of fluid boluses. And so the interesting thing here is that you see distinct outcomes in our model depending on how you treat the patient, how much fluid they administered, what their mean blood pressure looks like over the course of treatment, and again, their fluid resuscitation status with the urine output. Are we having like really large gains and losses in fluid, or are we kind of being more stable, like on the right side? So our burn model, I think I skipped one. There we go. So our burn model, again, we looked at 3 different burn wounds, and so there's a question on the unit surface area. This is just a fraction of the body surface area. So let's just say this is a pretty common input for whenever medics are evaluating a burn wound. They'll kind of fill out a chart that says what % of the body is burned with 2nd or 3rd degree burns, essentially. You can see that with a large burn, with a 40% of surface area burned, you see a large fluid shift. In fact, this scenario terminates early because the patient actually has lost so much fluid in the first 3-ish hours after their burn with no treatment. And so large blood pressure changes because of that, large increase in systemic resistance, and this is the body combating that fluid loss. This is the barrel response, trying to increase heart rate, increase resistance, keep that blood pressure up. And we looked at a treatment scenario with a burn wound. So this treatment scenario was designed, again, through our collaboration with USISR. So we looked at administering Ringer's lactate solution at 10 times the burn size, so 25% burn wound. So we start off at 250 milliliters of fluids per hour, and we increase that as needed depending on the urine output of the patient. You see that we gradually increase the infusion rate of fluid until we eventually get to a good resuscitation status. Again, as measured by urine output, it stabilizes. So you say, okay, the patient's finally at a pretty good point with their fluids. You can see we give about 8 liters of fluid over 15 hours of treatment, so quite a bit of fluid is given to the patient there. and you do see recovery in heart rate and respiration rate as we give pain medication and give the patient more fluids. So what we're going to work on in the future with this model is we'd like to introduce some model variability to the inflammation model with the perspective of patients. How does their response vary in terms of how all those inflammatory mediators interact? Variability in terms of the bacteria. So how does the growth rate change or various interactions thereof? And also increasing kind of the range of starting points. So right now we have a mild, moderate, severe infection as we determined how to best tune this model. Now that we think we have it in a good place, we're so expanding what are the possible ways to start this model, a lot more types of initial infection levels. We don't currently have a model of acute lung injury or acute respiratory distress syndrome in response to inflammation, so that would be a great thing to add. We'd like to do the fluid loss during burn a little bit better. Some of the fluid loss might be a bit excessive for large burns. It'd be great to add a model of coagulopathy in terms of the coagulation cascade gets kind of just as out of sync as the inflammatory cascade does during sepsis. And then also, for us, it would be interesting to define these inflammatory mediators as BioGears substances. So right now, they're just variables that we track, but if we actually define these as BioGears substance data types, then all of a sudden our circuit model and our substance transport model, those models will be handling the transport calculation of those chemicals throughout the body, which would help us improve the spatial resolution and do drug pathogen interactions on a more local level. Again, those are the big models. I do want to quickly go through just a couple of other things we've done. So we've expanded our Cerebral circuit model. And so part of the motivation for this was we had just a generic Windkessel model for our cerebral space earlier, and there was no cerebral autoregulation. So it basically acted like any other compartment in the body. Part of the problem with this is that the body prioritizes getting oxygen to the brain. And we actually were seeing during some of our sepsis runs in particular that as we were losing fluid because of sepsis, the brain actually wasn't getting as much oxygen as it should because it wasn't being prioritized like it would be physiologically speaking. So we wanted to increase the fidelity of this circuit for more accurate blood and oxygen tracking, and then introduce autoregulation to prioritize oxygen delivery. So this is our updated cerebral circuit. So we distinguish between cerebral arteries, cerebral capillaries, cerebral veins. We have compliance pathways that control the volume in each area. And this, again, is based off of some other work that other modeling groups have done. And we define this model in our code, and we tune the parameters to fit BioGears. The large and small resistors for the cerebral arteries, there's one before the arteries and one after. These two resistors are now subject to autoregulation. So they take in the blood flow and the perfusion pressure as inputs, and also the blood gas levels, and their resistance changes depending on those values to get to maintain constant blood flow to the brain. So this is what our autoregulation model looks like. Essentially, it's a first order control system. So you see just a lot of first order transfer functions there. So our inputs are, like I said, cerebral perfusion pressure, cerebral blood flow. We look at carbon dioxide partial pressure. We take the logarithm of that because it's more related to pH than it is to directly to CO2 pressure. And we also look at the venous oxygen saturation in the brain. And so all of these inputs are weighted, essentially, using these transfer functions. We sum them up, and that gives us a multiplier for those resistors on the circuit. And so if you're not getting enough oxygen or not getting enough blood flow to the brain, that resistor should decrease in value to encourage more fluid flow to that region. So quickly, just to show you, here's an example of our traumatic brain injury scenario. Generally, these results follow what you would expect. So the TBI is initiated at time 0. You see a pretty drastic drop in cerebral blood flow because of the injury, with a corresponding increase in intracranial pressure and a decrease in cerebral perfusion pressure. Autoregulation, you can see its effects mostly when we look at a hemorrhage scenario. So I ran out 2 hemorrhage scenarios. One autoregulation was on and one it was off. And so you can see the black line is with no regulation. You can see the cerebral blood flow is starting to decrease as we go along. And that will just get worse as the body loses more fluid. Meanwhile, while it's on, you actually see that we are, with the green line, we're preserving blood flow to the brain in spite of the fact that the body is losing fluid. So we don't have any short-term work planned on this model. Long-term, we might try to improve some of the blood gas tracking in the brain. That's probably the best way to increase the fidelity of this feedback model. And then we might be looking at some integration with other projects at ARA that deal with TBI. So I'll hit whole blood real fast. Just where our previous model worked is we just had one substance called blood that was circulating in BioGears, and it had various components like hemoglobin and various ions, but there was no sense of blood type. So our new model goal was to support ABO blood type definition, RH positive or negative, to distinguish between whole blood and plasma. So you can do either whole blood transfusion or just a plasma transfusion. And also to make sure we're checking for donor-acceptor compatibility with blood types. For our whole blood model now, the virtual patient, we have new substances. We have antigens for A and B. We have red blood cells, white blood cells, platelets, and we set these concentrations according to standard literature values. You can set RH positive to true or false. The patient can be AB positive, AB negative, etc. We don't track any antibodies for antigens. We just infer the presence or absence of them by which antigens are defined. And then we have a really good transfusion action now that Nathan's going to talk about in his multi-trauma presentation later on. Just to give you a sense for what is in the works, we're really close to finishing an integrated nervous model. So currently we treat all the feedback as separate entities. So the response of the baroreceptors, for instance, and the response of the chemoreceptors, they don't inform the other. They have outputs, and those outputs independently affect the system. So what we'd like to do is, in addition to increasing the fidelity of those models and introducing a few new feedbacks, is to have a consolidated signal that's sent out. So we basically take all the inputs from different parts of the body, blood pressure or blood gas levels, and get a single output that consolidates, the entire state of the body. And that output tells the sympathetic and parasympathetic responses how the body should respond. We're pretty close with this one. We're just going through a lot of validation on it because it basically touches every single part of our software, so you make sure that it really is working well. Possible long-term development, an updated nutrient kinetics model would be, I think, a nice addition to BioGears. Also, insulin glucose regulation, that would allow us to probably do some interesting modeling work with diabetes or diabetes management and treatment. So that wraps up what I want to talk about. I do want to acknowledge a lot of people that helped out with this work. With the sepsis model, Dr. John Keller with University of Washington, their Pulmonary Critical Care Center was a great help, as was the entire AMM team. The burn model, a lot of folks at USAISR are very helpful, giving us feedback and helping us develop good treatment scenarios. And then the rest of the BioGears team for all the support on this work. So if there's any questions I can get to, try trying to look at this at the same time here. I'll see if we have any time for them.
Hey, real quick, so just to let everybody know, we know we're behind time. Our BioGears Q&A segment that's going to be after the next presentation by Christy Burris on AI/ML applications. We're just eating into that buffer time. We basically scheduled that because we knew people would go over and we'd have discussions after talks. So we should still be on schedule to go to lunch at the same time, but we're just shifted by like 15 minutes. So, William, if you'd like to engage Matt, it looks like you have quite a few questions that I think could be beneficial to everybody. I'll unmute you and you guys can have a little discussion.
Thanks, Matt. Great presentation. Really impressed. I was just wondering about some treatments dealing with overpressure and also compression garments that are tailored to burn victims. Is there a way to factor that in, considering you were talking about fluid losses? And I think in the treatment of burns, that material augmentation due to the loss of skin is something they use often.
Mm-hmm. Yeah, so currently we don't have anything specific for, I see you mentioned hyperbaric chamber treatment and compression garments. I'd say the closest thing we have now is we have a tourniquet action, but that's more applied to hemorrhage in terms of trying to reduce fluid loss. We do have a somewhat generic environment model that controls like the humidity, the airflow, and things like that in BioGears. But that environment model doesn't, I don't think, interacts with the burn model as much as it would need to model hyperbaric chambers. So those are things that I think would be future work that we would need to focus on.
You know, I apologize for asking that because I'm just now remembering the previous presentation. BioGears is for operational medicine, and so those sort of devices and implements aren't available, I guess, when you're sending out a PJ or someone else, but more applicable to a hospital setting. So forgive me for that.
Oh, well, it's certainly interesting to think about. I mean, it got me thinking about hyperbaric chambers now, so that's good.
That's all I have.
I saw you mentioned something about how many real EHR. I'm not familiar with that acronym, so could you help me understand that question?
It was simply the electronic health record. I mean, what I can imagine,
I see.
talked about when you are in the next talk, is that of the tens of millions of treatments, you know, because of the way it has to be paid for, and the providers have to collect their metrics, like pilots have to, you know, collect flight hours and mission tasks on sorties and stuff, that there are some big data opportunities there in general if you guys could mine that overall and you know, prioritize your modeling efforts, you know, based on trends or historical type disease codings and or treatments that were used, and see whether or not the models line up pretty well, considering that you might have patients with comorbidity, so it'll be hard to say any one particular treatment in of itself didn't interact with an ongoing treatment.
Yeah, that's a really good point. We certainly acknowledge that at this point, the state of this model is very much what you might say is a average response to certain infections or treatments, and we think that the direction we have to go from here is customizing this to speak to, as you said, comorbidities, different patient populations, and I think it does start with getting access to some different data that we can target our models to in that respect.
Thank you very much. That's all I have. Thank you.
Yeah, no problem. Thanks for the question.
All right, great questions. So now we are going to, next up we're going to unmute Adam and have him give a brief introduction to the next talk and speaker, and then we'll pull up her talk here. So Adam, I'm going to unmute you, and feel free to start talking.
Testing. Can everyone hear me?